This week in Pediatric Oncology, the podcast exploring hot topics and exciting advances in childhood cancer. TWiPO is produced by Solving Kids Cancer, nonprofits located in New York and London dedicated to improving research and supporting families, because every kid deserves to grow up. Subscribe to TWiPO through your favorite podcast platform.
Welcome to This Week in Pediatric Oncology, the video podcast about new advances for childhood cancer. Hi, everybody. Welcome to episode 83. This is recorded on January 15, 2021. I'm your host, Tim Cripe from Nationwide Children's Hospital in Columbus, Ohio, affiliated with The Ohio State University. And I'm here along with my relatively new co-host, Brenda Weigel from the University of Minnesota. Welcome, Brenda.
Thank you, Tim. It's a pleasure.
Thanks for being here again. And we've got two guests with us today for our discussion on an important topic. The first guest is Dr. Christopher Dandoy from the University of Cincinnati, where he's an assistant professor and Cincinnati Children's Hospital Medical Center, old friend of mine, and a leader in the field of TA-TMA for bone marrow transplant. Welcome, Chris.
Thank you very much.
And our other guest is Sarah Moore, who's a mother of a patient with neuroblastoma, who I imagine this topic caused significant angst for when her son was undergoing a double transplant. But unfortunately, he, as my understanding, did not experience TA-TMA, but she's done a lot of thinking and talking about it and was concerned about it. And we have her here for her perspective. Welcome, Sarah.
Thank you for letting me be here.
Yes. So Brenda, why don't you kick us off with just a little bit of discussion about why this is an important topic, and then we can talk to Chris about his recent study.
Absolutely. And thank you, Tim. And it's a pleasure to kick off this podcast. So TA-TMA, or transplant-associated thrombotic microangiopathy, and we're going to call it TMA for the rest of the meeting, it's easier, is a devastating complication of cellular transplant. And it happens with all forms of transplant, but more commonly with allogeneic transplant, and also most recently been seen much more commonly in the tandem transplants that are used for neuroblastoma. And the challenge is it's a multi-organ involvement with small vessel injury leading to end organ insults affecting the heart, the kidneys, and multiple systems in the body, and can, in most cases, if left untreated, be very severe and life-threatening. And in the vast majority of cases has historically been life-threatening, and very few patients have survived, and those who have survived have gone on to have long-term complications with end organ damage, and other devastating complications are strokes and neurologic damage. So there are considerable concerns with this, and Dr. Chris Dandoy at Cincinnati Children's is really one of the emerging world's experts in the field, has many landmark papers describing the condition of TMA, but most importantly, and very recently just published in Blood at the end of 2020, a landmark paper utilizing a therapy for TMA, and actually was successful moving the bar for response by about almost 50%, which is incredible. So we are looking forward to hearing more about this incredible work and about the syndrome of TMA.
Perfect. Thank you, Brenda. And thank you, Tim. And thank you, Sarah, for letting me be a part of this. And what questions can I answer, or would it be best to just dive in?
Well, I guess I'm wondering first, sort of what led you to the study. Really is impressive. First of all, in its scope, you have 34 co-authors, and I forget how many institutions, but you collected a ton of data and so forth, and I think really moved the bar. But what led you to sort of want to do this study? Where'd the idea come from? What was important about doing this study? And I should say, it just finally, although it was published online in December, the official issue that it appeared in was 3 days ago. So we're really on a hot topic here.
Well, thank you. So really, this goes back to when I was a fellow. Sonata Jodell, who was my fellowship mentor, did or completed a prospective study looking for TMA in transplant recipients. They looked at approximately 100 patients and found that TMA, either moderate, mild, or severe, was found in about 30% of transplant recipients, and that was published in Blood back in 2014. We presented a lot of data from that paper, and we would present these data at meetings, and people would say, "Oh, that's just the Cincinnati Children's disease. Cincinnati Children's has a high rate of TMA, but we don't really see it." So what we did was we went to two different groups, the Pediatric Transplant and Cellular Therapy Consortium, as well as the Pediatric Acute Lung Injury and Sepsis Investigators. So Polisi, and then as well as the Pediatric PTCPC.
So these are three different collaborative, cooperative groups that are involved in transplant.
And then we went to the ICU folks, and they had a subgroup of just transplant physicians. And we said, "Hey guys, we don't have any money, but we think this TMA
Head start.
think this is a thing, and we think it's really impacting patients. Here's our data from Cincinnati. Here's what we propose. We want you to look for it. Here's how you screen for it. The screening is easy. I need you to look for it. Looking at blood pressure. I need you to look at LDHs on the patients that are admitted through the first 100 days. Look for urine protein to creatinine on your patients. You're using the data that we published in 2014. You're following evidence-based guidelines. Follow it. Just implement it into your practice, put it into your order sets, and screen all of your prospective patients. And then do what you will. If you want to treat it, great. If you don't, that's fine, but just look for it and know that it's there. And then what we did was they prospectively screened 13 institutions, and then we retrospectively, after about 1.5 years, we retrospectively looked at all the patients. So that's why we called it a pragmatic institutional approach, because again, this was free. This was people volunteering their time. That's why we have so many authors too, because that was the currency they received for participating. Hey, we'll write this up. We'll put this in the abstracts, but they screened their patients, and then we retrospectively looked. So what did it include? The screening looked for schistocytes, or broken down red blood cells in the periphery. You're going to need to talk to your pathologist, because sometimes they're not looking for it, or it's not as reported. So just look for it. Once a week, look at spot urine protein to creatinine ratio. Look for proteinuria. Look for the refractory anemia and thrombocytopenia. Look at LDH. Look for refractory hypertension. And again, that is something that oftentimes, unless you're looking for it, it can go, not that we just ignore hypertension, but you can say, oh, maybe the kid's moving too much or angry. And it's something that that folks can just kind of say, oh, it's just hypertension, it'll get better. It's something that, if you're not piecing it together with the bigger picture, it can be tricky.
Well, all of those things that you've described are very common in many of our patient populations, right, individually, right? So
yeah, individually, and but you're actively looking, and then if you're wanting to, it's not part of the screening. If you're starting to suspect that they have TMA, then you can order off this complement level or SC5B9. That was what we asked them to do.
How did you make the connection between increases in complement and this constellation of symptoms? How was that connection made?
So that was back in 2011, 2012, 2013. Again, with what Sonata was looking at, so she looked at a couple of different things. So one, she looked at look at the complement cascade in general, and looked at all of the different proteins. On top of that, she was able to see deposition of complement in biopsies or kidney biopsies. And so that led her to look in her prospective screening at complement, is complement activated? And it was in the kids that did poorly. So what she found is there's a high risk subset of TMA of kids that both had proteinuria or significant proteinuria and then had complement activation. Those kids were the high risk group, and those kids had a survival of 30%. So we said, you know what, you can do. And then as far as treatment, some people, we didn't say you have to treat one way or the other. This is what we do here, but just we want to know what you did. And then they reported it out.
So this was a massive data gathering exercise from lots of different institutions. How difficult was it to set up that, the important thing in clinical research is data accuracy, authenticity, right? So
Yeah.
How did you have them reported? Did you set up a unified portal? Did they email you,
Red cap.
charts? How did that work?
Yep, they had red cap. So they would enter in just the patient, patient 001 from center, from Nationwide or Cleveland Clinic, and they would keep track of who that patient was on their side, so that if they needed to reference back, they could. But what we had was all de-identified information.
So it was a centralized kind of data repository for you guys. They just entered the data freely, which is miraculous that folks were willing to do that. And is this something that is ongoing? Chris, are you continuing to track the data for TMA in this?
So our next thing, and we're going to be, I want to go back to these centers and say, okay, guys, it's been about a year. Why don't we look at these patients? What's happened to them now? We had roughly, in the allogeneic recipients, we had 16 roughly percent, or all patients included had about 16% incidence of TMA, 17%. Specifically in the neuroblastoma kids, what happened with those kids? Because 25% of the time after tandem transplant, they're developing TMA, and if you don't get on top of it quickly, it can be pretty detrimental.
That's a perfect place, I think, to bring in Sarah into this conversation. Sarah, with numbers like that, hearing that before your son went into transplant, and especially that you were doing this, going through a transplant at the institution where that had the reputation for the TMA, I guess, in a way. How did that make you feel? What were your thoughts? Was that something that was disclosed on the consent form? Tell me what you think.
Yeah, so actually it was stomach dropping and very, very surprising, honestly, to find out that it was that high of a percentage. I had heard some chatter just from other caregivers in general that TMA was out there, but I had absolutely no idea that it was that high of a percentage. And so it makes you doubt for a moment if this is something you really want to go through with, considering the high levels of toxicity. But what was really helpful, one, was being at Cincinnati with Chris that we're talking to right now. He's incredibly knowledgeable about it, obviously. And so he was very reassuring once we continued to have discussions about it. And I think that was shortly after going through the consent that we started our conversations. And there was a couple of things that really stuck out to me as far as bringing some reassurance to the situation. And that was one, that they're very proactive about screening for it, so they catch it very early. And then the second piece of it is that they get it treated quickly. And one of the things he mentioned that really stuck out was that if you screen for it quickly and get it treated quickly, then in almost all cases, at least at their institution, they've been able to proceed forward with the rest of treatment. And that was really important. Obviously, that meant that there would be enough of a healthy function in those organs that they could continue and finish out and not lose out on survivability. And then that also led to another question that I brought up to him. I said, well, looking back, at least in the neuroblastoma tandem studies, that was really based upon a time frame when they weren't actively screening and treating for TMA. So if we're now doing that at these institutions and actively screening and treating it, then is that likely to positively affect the overall survival and outcome for these kids?
That's a very important set of points you just made about it being reassuring. I think Chris and Dr. Jadell's work here in publications that will now enable all centers around the world to be able to be proactive and screen and treat. So Chris, summarize your findings again, the incidents and the sort of outcomes that you knew at the time, and then how you think maybe that's changed now that people's practice are shifting.
So we saw that roughly 17% of patients develop TMA. Now we have a cohort of people that are very invested. They are knowledgeable about TMA. Now they're screening, and they are actively, they're treating as per their institutional guidelines. And so we collected some of the data. We collected data on outcomes of these patients as well, including patients that were treated with complement inhibitors such as eculizumab. And the interesting thing is the patients that had the highest risk of disease. Remember, with our 100 patients that we did back 8 years ago, the overall survival was about 20% roughly. And although survival is lower in these high-risk groups, the patients that were treated still had a lower overall survival, but it was not nearly as low as that we saw before. Mortality was roughly 30%. Still not right. We still got a lot of work to do, but that definitely wasn't the mortality of 80%. There's other parts of that, not just mortality, that we've got to consider. So patients that developed TMA had higher ICU admissions. So their ICU admissions was about 8-fold higher than the patients without TMA. They required non-invasive ventilation at a much higher percentage, roughly 25% compared to 6%. Pericardial effusions occurred in 9%. So pericardial effusions is something that we don't talk about nearly that often. And these aren't just little small trivial pericardial effusions. These are ones that needed intervention. These are ones that needed pericardiocentesis or maybe a pericardial window. That occurred in roughly 9% of patients with TMA. Pulmonary hypertension occurred in 6% of TMA, and 15% of those patients that developed TMA also required dialysis, compared to only 2% that did not develop TMA. So these are other complications, and something that outside work on is bloodstream infections. So these bloodstream infections, if you're into quality improvement or healthcare associated issues or patient harm, bloodstream infections occur at a much higher rate in patients that develop TMA than those that do not. And so all of these different issues that are occurring in patients with TMA really add on to the healthcare burden, but then on top of it cause a substantial amount of morbidity. So we have a long way to go still to recognize it early, reverse it, develop and test other interventions. It's not just that eculizumab is the end all. I do believe in the future we will have further interventions, but then trying to dive in a little bit more of the interplay between GVHD and TMA, understanding more about endothelial injury in general, which kind of goes into the veno-occlusive disease, TMA realm, how those interact, and how that we can mitigate it early and turn it around.
I know in your paper you described how the allogeneic transplants have a higher risk than auto, I believe, if I remember correctly.
Yeah.
Yet, as Sarah mentioned, you had a 25% incidence in the neuroblastoma patients who were getting autos, so which is higher than the overall incidence of the whole study, which you said was 16%. So do you have any explanation for why certain subgroups of patients are at higher risk, especially autos, where you think of the risks of an auto to be much less in general than the risks of an allo?
And then you have to think, and so you think the patients that received busulfan and melphalan, or just one cycle of carbo, ETOP, and melphalan, those patients that just had one transplant, they did not have any incidence of TMA. So is it a second hit? You get the first pretty big dose of chemo from cyclophosphamide and TWiPO in the first transplant, And then you've already injured your endothelium, and then the carboetop melphalan, the second transplant, causes further injury, and then that starts a cascade. Again, we have more information, more learnings to do. We have more research that we need to do. There is a recent blood paper that Chris Dvorak wrote that he proposed this two-hit type process, and the chemo is one, and then maybe a viral infection is a second, or maybe it's GVHD that tees it off, and then it starts the complement cascade. But I think there's more to learn. And importantly, it doesn't happen in the CNS kids. So the kids getting 3 transplants, they don't get TMA. So why is it that these kids are getting it?
Is that because of a difference in their preparative regimen, their chemo?
Yeah, probably. Yeah, and it's not as intense as this.
Chris, can you comment a little bit on, you mentioned a few times of intervening early in treatment with the complement blockade, and also in reflecting all this data, it was left to different sites as far as their standard practice. Can you speak a little bit to that variability and trying to come up with then recommendations potentially with what does early intervention mean? What does that look like? What should be the triggers, in your opinion, to intervene with complement?
Right. So one is you got to screen and you got to look for it. And then once you meet 4 or 5 of these criteria, you should probably start treatment. We do eculizumab and we follow the guidelines that we've published. We have a prospective study, again, that Sonata's running a multi-center prospective study looking at eculizumab and treatment and how it impacts outcomes of these patients. That study should finish up probably sometime in calendar year 2021. But it is really, I think the first most important priority is just recognizing it, that it happens. And then starting eculizumab or another complement blocker. What we have seen, the kids that have done poorly, and we've had, we'll get calls and folks will say, I've got this kid now on dialysis after transplant, and we gave some radiation and it went okay, but the kidneys were in kidney failure. And now when we look retrospectively, we think this all started about 3 months ago. That's what you probably want to try to avoid.
Well, the other point you made, I just wanted to reemphasize a bit, is that there are a lot of different manifestations of this, a lot of different end organ, as we say, complications from the heart and the kidneys and elsewhere. And we know in general that patients undergoing transplant do have a lot of these complications, many of which lead to morbidity or mortality. And what you're describing is, I think, a strategy that might mitigate many of those or reduce the incidence overall and make transplant safer. So it could have a huge impact on the field, I think, if we could have wide implementation of early screening and early intervention. So that's really exciting work. Congratulate you on it.
Well, thank you. And it's the team again. All these folks that are part of the article, they all volunteered their time.
Yes, it's all a team effort. I guess we should probably wrap up on what the future directions are, your next studies. How do you make this more widely known besides just publishing it? Do you anticipate getting more and more centers involved, or what do you sort of think is next and the next big challenges, really?
So I think there's 2 learnings. One, I'll talk about TMA, and then one is an opportunity for our field in general. So the first is the opportunity here. I think there's more information we need to know as far as just an observational information as far as long-term effects. What does TMA do? How does it impact our patients? I think there's more opportunity to test different interventions. So when Sonata's study wraps up, I think that will be able to be spread and trialed in a larger mechanism. And then we just need to get the data out there and then get this, such as you folks are doing right now, getting this out to our colleagues out in the community, just increase awareness. The second is this pragmatic approach. So if you think about, I started nagging centers probably in 2013, 2014, when I was finishing up my fellowship, like, hey guys, we can do it, we can do this, and getting them all excited to go. And then we got it rolling, and they implemented it in 2016 or so. So maybe it's 2014 and 15. But if you think about what this would have cost to do a 13 center prospective screening to help understand TMA, this would have been a multi-million-dollar study, right? A multi-million-dollar observational study, and years and years and years to try to get it up and running. We would have been writing R1s, and then they would have rejected, and then we would have sent it over to somebody else, and then they would have rejected it too, and then we would have been like, oh, what? So we have to think about how we do in real world observation and learn from our experience collectively. How do we do that? How do we learn from each other? And I think there's a great opportunity. Jeff Valletta over at Nationwide, we're setting up this learning network that we can learn from each other in BMT. I think that platform and trying to have a directed mechanism to learn from each other is how we want to move this field, and how we'll be able to take advantage of shared learning and collaboration.
Well said. Sarah, any final comments or questions?
No, speaking to the caregivers and parents, I just study up on TMA, try to understand also the symptoms of what to look for as this continues to roll out to more institutions and they get on board. As parents, the best thing you can do is just advocate for your child in the meantime, and try to get on top of it and reach out to your care team if you suspect TMA at all.
Great. And Brenda, anything final?
No, I completely echo Sarah's final comments. I think this is, and building on Chris's, it's increasing awareness and recognition by the caregivers, and parent advocacy certainly helps with that, to recognize those early signs and symptoms of something that could be passed off as just being part of medical care. So if you put all the symptoms together, it may be telling you something, and there are potential strategies to intervene, which I think Chris's data clearly points out that if recognized early, there are strategies that may make a difference. And this is, I think, a real opportunity to change the field and change how we think about some of these complications of transplant.
Great. Well, thank you for your comments, Brenda and Sarah, and thank you, Chris, for being here and all your great work, and congratulations again. And thanks to the team at Solving Kids Cancer, a nonprofit charity dedicated to improving survival through creating novel treatment options for children, for sponsoring this video cast. Remember, the more we learn, communicate, share ideas, and work together, the faster we'll reach the day when all childhood cancer is preventable or curable. As always, keep up the fight, and thanks for listening and watching to This Week in Pediatric Oncology.
We welcome your comments, questions, or thoughts on topics for future episodes. Just drop us a note at TWiPO@solvingkidscancer.org. You can follow Dr. Cripe on Twitter at KidsOncDoc, and find all TWiPO episodes at solvingkidscancer.org.